Our next presenters will be joining us together from two separate locations. So we'll hope the technology gods smile on us for that this morning. Haven Wheelock has been advocating for the health and safety of people who use drugs since 2002. She is the Drug Users Health Services Program Coordinator at Outside In here in Portland, Oregon. She provides in direct service with people who use drugs and have been involved in creating policy that improves the health in Oregon. She completed an MPH as a fellow at Johns Hopkins and is part of the Bloomberg American Health Initiative focusing on overdose and addiction policy. She was also a chief petitioner for ballot measure 110, which was a first in the nation initiative to decriminalize drugs in the state of Oregon. Her co-presenter, Justine Pope, is an emancipatory activist researcher, daughter, harm reductionist, bookworm, volunteer, bicyclist, you name it, with an abiding commitment to social change. She's dedicated to asking questions and finding solutions to issues that seem insurmountable. She's up for it. She received her MPH from the OHSU PSU School of Public Health and has been learning from and with other harm reductionists since 2017. She's the co-founder of the People's Depot, a low-barrier can return program that started during COVID-19. That made a huge impact. I'm hoping she'll tell us a bit about that today as well. She's grateful for the friendship, kindness, resilience, and brilliance of people who use drugs. How refreshing is that? Please join me in spending some time together with Haven Wheelock and Justine Pope.
Thank you so much. It was a really kind introduction. Hi, everyone. I'm Haven Wheelock. I run the Drug Users Health Services Program at Outside In. As was previously stated, I have been working in harm reduction for 1 billion years. I am involved in both direct service with folks who are using, as well as some policy stuff, and working on some cool big picture as well as direct service work around drugs and drug use. And I'm really excited to be here, and you're in for a treat because Justine and I have a fun little banter. So please bear with us, and thank you for paying attention. Justine?
Thanks, Haven. Yeah, and thanks, Paul and Care Oregon for having us here today. I also just want to point out I'm here talking about my work, particularly as a volunteer, so I'm representing my own personal opinions. That being said, I'm really excited to talk about harm reduction with Haven and with all of you. I am what I describe as a baby harm reductionist, and I met Haven back when I was in grad school. And I remember just getting served some realness by Haven, which I am very, very grateful for, as well as just acknowledging that harm reduction is something that I have learned by and with other people who use drugs and other harm reductionists. So I want to offer just gratitude for the folks who I've gotten to learn from.
Are you calling me old, Justine?
No.
Okay, just checking. All right. So we've got some like kind of learning objectives things. We're going to kind of go over basically an overview of harm reduction, what it is, how we got here, why it matters, kind of stuff. Some real basic principles, ideas. I think we'll dive into this later, but some of like just the nuts and bolts of like the tools of harm reduction, as well as some of the philosophies and practice around harm reduction and why that really matters. How you can integrate that into your system of care, how you may already be integrating it into your system of care, but don't recognize it as that. We'll talk a bit about some like tools for working with folks who are actually using, and then we'll talk a bit about like language and self-care and like why all the ways that we can do better as providers to better connect with, serve, and be of service to folks who are using. Mm-hmm. So next slide. So disclosures. I think Justine and I both start every presentation we ever give with, we love people who use drugs. I think it's really important to start that way. People we love use drugs. I would trade most normies for people who use drugs any day. So I think that that's really, we come to this work through love, and because this population is so marginalized and criminalized and vilified, We want to hold those people first,
Mhm.
and we want to hold them with as much kindness and respect and dignity as we can give them. So that's our first disclosure. It sometimes sounds like we're like glorifying drug use. It's because we love the people who are using them. We're committed to systems change. We're committed to building a better society and better healthcare systems and systems in general. Neither of us have financial disclosures. So this is just us showing up with our big old hearts and our really excited, and our excitement for the people we serve and wanting to share that with you. So harm reduction overview. This is me. So I love talking about the history of harm reduction, and as I may be a shoulder that Justine stood on to learn skills, I also come to this work a little later than it started. I've been working with people who use drugs since about 2002 specifically, but there were people doing this work long before I was and long before many others. So I think it's really important to honor our history, and I think it's also a fascinating history. So the term harm reduction was really coined in the late 80s, early 90s, and it was really, at that point, it was talking specifically around drug use and HIV prevention. This work comes out of HIV prevention, but before it was ever formalized, it was people using drugs who were making sure that tools of harm reduction were in their community. When I talk about Outside In being the third legal syringe exchange program in the country, I use the term legal very intentionally, because long before we were doing it legally, other drug users were doing them for their community already. And I think it's a really important thing to honor. So it started out of HIV, it started out of activism. It has always been a radical idea, and it's really cool that we are moving into a place where it is more normalized. 10 years ago, Care Oregon would not be doing this presentation. We would not be asked to be having these conversations. And so I think it's really important to honor that that has changed, but we also need to continue to honor the roots we came up on. So it's based out of this radical belief that we have to take care of each other no matter what. And that it really started as drug users taking care of each other and trying to prevent the spread of HIV in our communities. It has since moved into all kinds of other realms. We talk about harm reduction in all kinds of different ways, and we'll touch on some of that going forward, but it started in HIV, kind of like in my world, like when I first started, we were doing HIV prevention and really a lot of testing and connecting to care, because I started in 2002, so we actually had medication. People who started this work even 5 years earlier than me didn't necessarily have access to medication. So they may have been testing, but they didn't have any intervention to follow up with. Now that moved into talking about hepatitis and hepatitis C, and like, as you know, when I first started, we were still referring to it as hep non-A, non-B. And so as we've moved forward and like doing interventions around hep C treatment, hep C testing, hep C prevention was a key part of this. As the overdose crisis has taken over, that's the primary angle where people talk about harm reduction these days. It's also probably the most accepted part of the world of harm reduction. People tend to feel a lot more comfortable talking about naloxone and overdose prevention than they do about safe injection facilities, syringe access, those kind of things. And so I really hope that I hope you walk away from this training feeling stronger about the importance of these interventions, and more normalizing even some of the stuff that like feels a little fringy. We're moving in that direction. So just in case you guys don't know, the man in the middle is on this slide. I love this image. That's Dave Purchase. He started the first legal syringe exchange in Tacoma, Washington in 1988. So it was a card table on the street of Tacoma. Rest his soul. I missed I miss him every day. The other two photos, one is ACT UP taking over the FDA for AIDS medications, and VANDU, which is a drug users union in Vancouver, BC, fighting for harm reduction services in Vancouver. So next slide. So this is where this all gets like a little messy. So when harm reduction first started, we were also in the beginning of our escalating drug war. So we're talking the mid 80s, and we have this idea that people who use drugs are everything that is wrong with our communities, right? Any possible issue that could be happening in any community anywhere was being blamed on drugs. And at that time, there was a lot of vilification, criminalization, stigmatization of people who used any substances, in particularly Black and brown people who use substances. And the war on drugs really served as a tool to tear apart communities of color, to justify that. And harm reduction services at its core, and we're still, to be honest, we're still fighting this today. Like, this is still something, and like we're seeing, and it invades our thought processes when we think about people who use drugs. I would venture to guess there are few people on this call today who remember a world without drugs, or without a war on drugs, right? Like, the war on drugs has been active since the 70s and continues to invade the way we think, the way we talk, the way we act around drugs. And harm reduction really was a tool to kind of push back on some of that. And it's still an active tool to push back on that. The harm reduction community has been saying for years that the criminalization of drugs and the people who use them is harmful to the health and well-being of those people and is not actually protecting our community. So it is an active process to try and correct some of those wrongs. And again, that makes me really grateful that y'all are here today, because you're taking part in learning on how to do better than what we have been taught historically. So next slide. So this is like part of like me with my like fancy MPH has so many conflicting feelings when I think about harm reduction in general, because I think that it's just messy and complicated, which is part of why I love it so much. But it really initially was around a public health response, right? And for years and years and years, it was really like harm reduction is public health. And it was grounded in that. And it was about preventing HIV. It was about preventing hepatitis C. It was about preventing the overdose crisis. And that stuff is all still very, very, very true. And it's very, very, very important. However, you know, in my decades of doing this work, we're seeing more and more of it also being talked about as a social justice, through a social justice lens and a social justice framework, and how we as a community are responding to the syndemic of all of the messiness that is part of like the lives of people who use drugs. And so we're looking at how do we build equity and power amongst the people we serve? How do we make sure that their voice, right? To go back to the old HIV like adage, like nothing about us without us, right? That is something that the HIV community has been saying for a long time. And we're doing a better job today than we were 10 years ago at making sure that those voices and people who are using drugs are at the table. I would still say we have a long way to go. I would say most of our tables have former drug users at them, but not out and open current drug users at them. You know, you see a lot of people clap when someone says, I've got X number of years of sobriety. I don't know that people would clap the same way if someone said, I use heroin every day. Mm-hmm. And I think that that's really important to like remember as we're thinking about who's at our table, what tables we're creating, mm-hmm. How are, like, do we actually have drug users at the table, or do we just have people who used to use drugs at the table, because those are, while sometimes the same, also can be very different, especially depending on how long somebody has been out of the drug market. I think I see a lot of situations where people with long-term sobriety, and good for them, and I applaud them as well. However, if you are shooting heroin today, you're dealing with a whole different world than somebody was 5-6 years ago. We didn't have fentanyl in our drug supply 5-6 years ago, right? Like, I look at documentaries on overdose that were made, 5 years ago, and the word fentanyl is never in them. And so, I mean, I really think that we are working as a movement and as a group of people to really try and like bring that equity and lift those voices in really honest ways.
And thank you, Haven. I'm looking at time too. And so before transitioning to the next section, I really appreciate what you said. I mean, always, but also I'm thinking about having done things like participate in the political process. Like, it's so much easier for me as a young, white, educated, someone with a lot of capital, social, financial, and privilege. And then I think of the bravery of friends of mine, and there have been some who, I'm thinking of county hearings, have shared in their testimony that they are active drug users. And the risk that someone puts on themselves to disclose that is, I think we can all understand why someone doesn't want to share that, especially if it's in like permanent testimony, or things like, that where it's still technically illegal, like the types of risk that someone assumes to add that piece of information. And I also think when you and I talk about how do we have systems that better serve people who use drugs, part of that is not just needing to say, well, I've been in recovery for 8 years, that it's just, there's more, I'm losing my words right now, but can you finish my sentence for me, or are you tired too?
I think I hear what you're saying is that like we really need to like be like honoring those folks that are willing and able to like bring their voice to the table and like share their experiences. And also it does, I mean, I know I don't disclose my drug use to folks, right? It's no one else's business. There's a lot of risk that is involved, right? But I think in my dream world, someone saying, yeah, I sometimes use drugs, would not lead to my provider needing to do an intervention, right? Like, it would not lead to like fear of losing my job, fear of being arrested, like those kind of things. Was that what you were trying to say, or did I just like project?
Yeah, no, you did great. It's all good. It's totally great. And with that, we're great for timing. We'll move on. So thank you, Haven, for offering that kind of like historical and some political context around harm reduction. Now we're going to talk for maybe the next 10 minutes just about some like basic principles of harm reduction. And so I also want to acknowledge that there are, hundreds of people on this call today, and you're coming from all different sides, likely not just of the healthcare system, but like of the social system that we live in. And so really the goal today, or in how we're talking about it, is that everyone feels like there's a way for them to access or to relate to understanding harm reduction and understanding the principles and the practices behind it. So that being said, here are some really high level kind of philosophical, let me back up for a second. Want to talk a little bit about the like philosophy, like the structure that underlies harm reduction approaches. And so we'll come back to things like respect. You hear a lot, meeting people where they're at. We'll talk about, this idea of love and compassion, no matter where you are in your use that day or that moment or that year. But really, we'll talk about the strategies, but underpinning all of this is that there's a deep belief, honor, respect, and love for people who use drugs, and that they have rights, and none of those go away, no matter where anyone is along the spectrum of managed use, or abstinence. So before moving on to some of the examples, Haven, is there anything you want to add about the kind of philosophical orientation of harm reduction?
I don't think so. I think you got like most of it. Again, I think that there's the philosophical beliefs and then there's the tools.
Yeah.
And they are both crucial and they are both covered in this slide deck. So
yes.
keep going.
Okay, great. So some examples of
actually, no, before you move on, I actually
Yes.
want to go back to that last slide because I thought you were going to say more about this other than reading it. I hate when we define harm reduction as meeting people where they're at.
Ooh.
And the reason I say that because it's only half the sentence. To me, yes, it is important to meet people where they're at, but it's more important that we don't leave them there, right? And so, yes, we go to where people are at and we will meet them there. And if they want to move forward, we're going to give them the tools, the skills, the like hope that they can make those decisions and do those things. But if they don't, then we're going to stand with them there and be with them in that space. I think harm reduction is a lot more active than it often gets credit for, right? Like people doing harm reduction work, it isn't just let people do whatever they want. It's like, how do we use our motivational interviewing skills to like help people tease out if that is actually what they want to do or not? How do we give them the strength and the tools and the hope and the vision to be the happiest, healthiest people that they can be, right? Yeah. And that doesn't necessarily mean sobriety. That doesn't necessarily mean abstinence, but we want to help them move towards health and help them move towards hope.
And let them, appreciating what you're saying, Haven, too, it's like, let them drive what that looks like for them. And I think a point that hopefully we'll come back to is thinking about folks, if you're using drugs and living outside, a lot of decisions are often made for you. And so something that I love and what's brought me to harm reduction is like that you're letting people express their own individual agency, their own autonomy, and their own decision making. And can we make sure we come back to that kind of throughout, or I want to like respond on it again. But before that happens, just want to give some like practical examples of harm reduction. So we today are going to talk more about harm reduction as it relates to lots of types of substance use. But like one thing about COVID is that it's given many more people access to like what harm reduction is. So like masks, like the idea, when I talk about harm reduction, I say, we live in a world that is inherently risky. And so harm reduction gives us tools to help kind of mitigate or decrease that risk. So like I'm a bicyclist, I wear helmets because they protect my brain if something bad happens on a bicycle. Seatbelts are another very obvious example of harm reduction. I put cigarettes in there both to point out that filters are harm reduction for smoking pure nicotine, and also there are many people who might be decreasing their use of substances and like smoking cigarettes in their place. And I really think, thank you, Haven, I think it's really important to acknowledge when we're asking someone, okay, you want to be in recovery, so quit smoking, quit shooting dope, quit, any substance use. I think it's really important to say, what's most important to you right now? And if you're using something else to like help you kind of keep your eyes on that goal, let's support it. And Narcan, which is a big thing. So visual examples. I'm going to kind of detour and then we'll come back to other practical strategies, but this is a slide about syringe service programs. They're often what first come to someone's mind when they think about harm reduction or harm reduction work. They're an important and critical leg of the stool, and there's also much more to harm reduction services. So just tossing in here some evidence for you all to reflect on, but also we're going to be talking about more than just syringes and access to syringes. Okay, so one of the things when I think about harm reduction in practice is harm reduction is about like love and joy and community work in service and with your community. And so a lot of times, even when we see news stories or anything about the opioid crisis, it's like pictures of pills and syringes on the ground. And I really like to acknowledge that that is a part of substance use, but also like hanging out with your friends and putting sharps containers on bicycles and riding them to bring to people who need them is also harm reduction. carrying supplies, you know, blocks to set up every Saturday in one of the larger homeless camps in North Portland. And going exactly to where the people are is also harm reduction in practice. So just a shout out, these both are photographs of volunteers with the organization I've been with for a number of years now called PPOP, or the Portland People's Outreach Project. And we're an all volunteer, peer run, peer focused organization that operates 3 days a week around Portland. But you might also be wondering, like, cool, harm reduction's about love, harm reduction's about meeting someone's needs. Like, what does that look like? And Haven, I was flashing on that picture you shared of the first syringe exchange or syringe services in Tacoma. And like, sometimes things don't look all that different. This photograph here was taken a year ago when we were told that we couldn't have a table where we were operating because the table was considered a structure. So we had to put our supplies on tubs, and tubs on a tarp on the ground under a tree. And in those tubs are the things that people who inject or smoke drugs need to keep themselves healthy and safe. And so that could look like clean needles. It could also look like works or other sterile injection equipment. So things like cookers, cottons, ties, alcohol wipes to clean someone's skin, clean water for folks who don't have access to consistently clean water sources. Naloxone or Narcan is a really common tool that harm reductionists will distribute. Also wound care or first aid. So people who might get skin infections or have just any other common skin issue that can be harder to heal, we provide them with first aid supplies. We also offer safer sex supplies, smoking pipes and foil. We'll come back to talking about snort kits and fentanyl test kits, and then also ways for people to collect and safely dispose of their syringes. And, you know, this is just another photograph that was taken during our snowpocalypse weekend the other day, but we had a bunch of volunteers still show up to keep services going on the cut in North Portland. And so we're not just offering, well, we're keeping services stable, but we were also offering, and have been for almost a year now, hot food every week. For a long time, we've been working with clothing donations. We're getting tarps and tents. We're meeting people's basic needs. We're offering support for folks if they are trying to find housing or shelter, can help schedule medical care or get treatment. I mean, a lot of people who, especially if they're living outside, things are harder, like keeping a phone charged, being able to make a phone call, access a medical appointment. Like both Haven and I were co-authors on an article about how Syringe Services helped facilitate access to telemedicine for buprenorphine. So part of, well, I'll go down the list. We're now, so when I say we, I'm talking about PPOP, but I want to acknowledge that we have other harm reductionists who may or may not be offering these same services. We're doing on-site testing, working with Central City Concern and Cascade AIDS Project so folks can get screened for HIV and Hep C. We're doing OHP enrollment. We've offered expungement services. We are bringing tablets with Wi-Fi so people can get their stimulus payment or apply for unemployment. And also just this past year started a low barrier CAN return so people can get their income needs met. So like, it's not just about the direct material supplies, it's also what are the other supports that someone needs in their life, again, to keep them healthy and well and happy. And overall, when I think about like what else is just, obviously we'll love and support someone if they're using drugs or if they're not using drugs. And so that is kind of non-negotiable. Yeah, Haven, what do you want to say?
I was just going to jump in. Like, yeah. I mean, I think while you just like clarify that this is what PPOP is doing, I think for the most, like, while not all harm reduction services do all of the things, I mean, it's pretty universal that most of us, like, if we all had the money we needed to do the work the way we would want to,
yeah, we
would all be doing those things, right?
Yes.
And I think that it's really important to like, it's all really like, again, it's an active process, right? We're working with folks to help them get their insurance turned on, because having health insurance is harm reduction.
Yes.
Having housing is harm reduction. We see people reduce their use and reduce their risky use when they go inside as opposed to being outside. And so I mean, I know you're outlining specifically what PPOP is doing, and what PPOP is doing is excellent and wonderful. And I would argue that all of the harm reduction programs that are truly living the philosophy of harm reduction and not just operating as a public health intervention are also, if not emulating this, they would be if they could be.
Yes, yeah, totally. And I think, and Haven, that's such a good point, because it's like, it's taken us time, a lot of time, to build up all of these additional services. Like I talk about a lot, like calling it like stacked services. So someone can come to one place and get so many needs met. Now they can get a meal, they can get a tent, they can get their cash for the week, they can talk to an OHP assister. But like so many harm reductionists are facing so much challenge just to even exist, that it can be hard to think about expanding services. And so, yeah, absolutely, it's not, want to echo that, because I think if we were able to offer all the things in the world, we would, but it's a real challenge just to sometimes keep our doors open or keep our table up outside. And it is also testament to the resilience of all harm reductionists who are facing often a lot of not just adversity, but like real opposition to even offer their services. And so that is significant.
I mean, even currently right now, right, there are syringe exchanges who are being sued and forced to close, right? Orange County just won a lawsuit in order to be able to keep their services up and running. There are states that it is still completely illegal. I think it's important to remember, like, you can't use federal funds to buy syringes, right? Like it was a few years ago now that they lifted the ban on funding syringe services program. There was a federal funding ban for years, decades, that said no federal funds could be used to run these programs. That has been lifted. However, it is still not legal to use federal funds to buy syringes to give to people to prevent HIV. So I think that like the real barriers to doing this work in many, like Oregon, we're pretty lucky. We've got a lot of support now. However, like when I first started here 7 years ago, or not 7 years ago, 2006, like it was really hard to get at the table to have these conversations. And like, while it was, and there's still many places across our state where access to syringes is next to none. So, I mean, I think it's really important to like call out that we're all doing great work. We all want to be doing that level of work, but even if you can only do a part of it, you're still doing better than doing nothing. Keep going. Sorry.
I was like, oh yeah, lawsuit in Southern California. You know, I had a lawsuit threatened against me personally by a man in my neighborhood who's a lawyer for doing what's happening in this photograph. And so it's kind, you know, it's anywhere and it's everywhere. But picture time, super fun. Something else, when I think about harm reduction, and one of the many reasons that I continue to be drawn to it, it's like, it's about the services, but really it's about building community and building power. And so these are two photographs on the one side with all the cans. That's a group of folks. We started a low barrier can return, and we've now distributed over $100,000 to people who are earning income, people who return cans, who are relying on income, who had their access to income just so threatened and challenged by COVID. And it has been low barrier job creation. It has been community building. Yes, Haven.
Justin, can you explain to me how did COVID affect people's ability to make income on cans?
Oh, that's such a good question. Thank you, Haven. And again, you know, I didn't have this idea. My friend who lives outside, when I saw him on the cut, I said, yo, how's it going? And he said, well, things are really hard. I can't return any of my cans in the grocery store. So understandably, a public health response to an unknown pandemic would be to go into types of lockdown to minimize services. But for people who rely on can return income, they had essentially for, I can't remember how many months, so I don't want to misquote it, but we had a state exemption. So grocery stores did not need to accept cans. The only places they could go were the bottle drop return centers, which were faced with hours-long lines, security guards, threats by community members. It required travel long distances. So instead of being able to go to the grocery store down the street, people needed to travel much farther. There was theft of cans. Like there was a big, it was a big moment of upheaval. Like the informal recycling economy is something I have been lucky enough to learn a lot about over the past year. But yeah, COVID and canners really upended for a lot of people who relied on this as a main source of income. And if someone uses drugs, if someone lives outside, chances are it's going to be harder for them to have a formal employment. And so this type of informal employment is one of the most like crucial ways that people earn just the money they need to, I don't know, live, buy food, bus tickets, whatever. So yeah, COVID really threw a wrench in that. But the People's Depot has been, again, not enough to meet all of the need, but a really inspiring way to think about we're building jobs and we're building community. And it's really a peer run effort. And for me to be able to see things like super low barrier job creation has been exciting, really exciting. There's another picture with a shout out to a radical lawyer friend of mine, Emily Youngie, and I believe it was the PCC criminology department, but they worked with us and the Baptist Church in North Portland and helped us set up and fund and feed. And the Alano Club of Portland also supported that as well. Forgive me, like it's building community on the cut, but building community with our other community partners. We were getting folks' records cleared, their records checked and cleared, and money for them to go get their record cleared, like all in one day. And I think, again, as I've learned from my other friends so much about how damning convictions and felony convictions, or even just an unknown criminal record can be, and then how empowering it is when someone says, I didn't know what was on my record. I didn't know I could get that cleared. Now I can apply for a job. Now I can get that fine taken care of. It's really magnificent. And what else would you like to offer around basic principles, if anything, right now?
I mean, just in general, I think the guiding principle and the guiding light is like to respect the autonomy of people who use drugs. One of the things that I really like about harm reduction in general is that it's also really realistic, which is very different than a lot of things. You know, like if we had a magic wand that would cure all addiction, not all drug use, all addiction, those are two very different things. I would run around town with that magic wand, tapping everyone on the head as quickly as I possibly could. But harm reduction really knows that that's not the case. Oregon is literally 49th or 50th in the nation for access to substance use and mental health treatments. And so harm reduction is something that shows up and can fill those gaps where other things don't exist, right? We know that our systems are broken. Our systems don't work for a lot of people. And so one of the beauties of harm reduction is that it is this world where people can receive care, can be treated with dignity and respect, can get the things that they need, can learn about what they're doing and get their questions answered in an honest, truthful way. In a system where, like, realistically, if I want to get someone into treatment tomorrow, I probably can't for inpatient. Like I might be able to get I might be able to get Suboxone, which is gold standard treatment, which is awesome. It's also really hard to take if you're living outside and get your bag stolen every day, especially if they know you have Suboxone in it. And so I think one thing we didn't really touch on is that, like, at the end of the day, really practical, right? Like nuts and bolts, like if we accept that addiction is a chronic relapsing condition, we need to have a safety net for folks in general. In general, we need a safety net. And I think harm reduction really does hold that place, right? Like with the pandemic, we're seeing people resuming use. Like I just talked to a guy today I haven't seen in 5 years, right? He's 5 years, had been stable, not using. His mother died of COVID. And here he is resuming use. And, you know, like, I love that he knew he could come back.
Mhm.
I was happy to see him. I'm not gonna lie. Like, am I sad that he's resuming use if he doesn't want to be? Yeah, that makes me sad. And this is a human that I've had hundreds of conversations with, and I was happy to see him.
Yeah. Well, and I think too, because we're going to talk about what folks often call the continuum of care, but I want to point out that I like crossed out continuum and wrote galaxy of care, because one of the things when I think about is like nothing is linear. Like use, recovery, use, abstinence, like we talk about, like even I said it before, like the spectrum, and I'm trying to interrupt my own naming of that because nothing is linear, period, especially someone's relationship to substances. They may have 5 years of active abstinence or sobriety, and then in one day have enough triggering events where they return to use. And like, so again, thinking about Haven, what you and I are committed to is like, how do we as public health practitioners, as healthcare practitioners, but also really just humans, like how do we build a system or a network that allows supports wherever someone is just that day? And so I think about it as much more like, yeah, not like a line, but like, I don't know, a galaxy. Okay, so we are going to talk about thinking for a little bit around healthcare systems. So some of our next slides, oh yeah, reflection questions. Maybe just think on this and we can come back to it, or we can talk about it in the chat or come back at the end. But be reflecting like, before or since what we've talked about today, how are you seeing yourself as practicing harm reduction in your work or also maybe in your life? So choose your own adventure as you look at Mirror Lake and the Wallowas there. And that might be generative. But now Haven and I are going to kind of tag team, really thinking about some like check boxes of like, how am I harm reductioning in a healthcare system? And it's not going to be that reductive, but we're going to go across a couple like general buckets or categories. The first one is naloxone. And so especially if you're working in a healthcare system, or if you have friends who are using, how do you talk with people? How do you talk with them about naloxone? If you are any type of provider, if you are a peer, if you are a CADC, if you're a nurse practitioner, any of these roles, how do you ensure that the person you're working with has naloxone? Like, first of all, how do you talk about it? How do you make sure someone has it? Are you familiar with overdose prevention and reversal, which we understand Melissa Brewster is also doing some great work in this meds ed around. But then something that I like ask folks is like, have you personally ever tried to get naloxone at a pharmacy? Like I have. It's not always a really smooth or easy process. And in fact, it's often not. And so when we think about things, you know, in addition to the work where we want to kind of make sure that pharmacists are more understanding, and so many have a great respect for our dear pharmacist friends, but that there can be real barriers to going to a pharmacy. So how are we also in the systems that we're building aware of other ways that folks can get low barrier naloxone? So that's one way thinking about the galaxy of care. Anything about naloxone before moving on, Haven?
I never like to assume somebody knows what naloxone is. And so for folks who don't know,
yes,
just because I've had this conversation enough times with people in a variety of settings where people don't know. So if you don't know what naloxone is, it is a medication that's been around for a very, very long time. It's safe, it's effective, and it works to reverse an overdose event for opioids. Again, we know that there's a whole thing on it happening later or maybe happened before, but just defining what we're talking about.
Oh my gosh, thank you so much, Haven. And I just appreciate like lots of things. And also there are times where I'm so familiar with like what this thing is, and I just absolutely assumed that people knew what naloxone or Narcan was, which is so not true. So thank you for making sure we like address that in that way. Yeah, life-saving medication.
This is why we're a good team.
Yes. And also, like, if you guys can see on your screen, but another thing, we'll talk about language later, but like, this is one of my favorite overdose response posters, because it's not like scary and a person on the ground, or like, in some dark alley somewhere, it's like using just like a bear and a kitten. Because like when I think about naloxone, I'm like, yeah, how do we think about breathing, and how does it feel more approachable? And it's just, yeah, I think there are different ways we can model that in our language and in how we're showing things around overdose risk.
I am gonna like push back though a little bit though, as somebody who's reversed many overdoses. Like, I think it's important, especially if you're working with patients, and like to acknowledge the trauma that comes from responding to an overdose. Like, responding to an overdose isn't cute kittens and fucking bears, to be honest. It's scary and it's hard, and all the training in the world doesn't make it that much easier, right? Especially outside of a medical setting, right? I don't know how many people on this call have had to reverse an overdose on the side of a freeway in the rain, but it sucks. And so let's keep moving, because again, you and I can keep doing this all day long, and we do have a time limit.
45 minutes, safe for use. Haven, go ahead.
All right. So, you know, I think there's a lot of things that, there are a lot of ways that people can use drugs in safer ways in general. And I think as providers, as people who are talking to people who use drugs, I think, one, you don't know better than they do necessarily. And like, you know, you can, one of my like biggest pet peeves is like providers who ask me questions about drug use. Like, I'll get a call and it's like, I'm working with this person and they said this thing and I don't know what it is. I encourage you to be humble enough to ask. Like, if someone references a drug or uses a term you don't know, just ask them. It gives them power. It makes them feel important and like they know something, because they do. But I also think that, you know, as providers, having an understanding of how people use drugs, it's not like it is in the movies. Don't assume because you've seen Trainspotting, you know about shooting drugs. And really like being able to like educate yourself. I really appreciate that Getting Off Right is one of my favorite bits of information. It's a book put out by the Harm Reduction Coalition. You can actually just Google Harm Reduction Coalition, Getting Off Right, and the entire PDF is online. It's like 80 pages. It's written for drug users, by drug users, really practical, really easy to read guide on some safer use stuff. I will say it's old, and I will say it's East Coast centric. So there's not any, again, no mention of fentanyl. Fentanyl didn't exist then. No mention of methamphetamines. That's not a thing. Again, because of when it was written. I think they should update it. I've said that to the Harm Reduction Coalition as well. But, you know, I think that like if you're just trying to get a good idea of how to think about safer use, it's a really great resource for folks. You know, there are a lot of ways. Injecting is more dangerous than smoking. That being said, people who inject rarely go back to smoking if they can help it. And so like really being comfortable with having conversations and getting told no at any suggestions you have is really important. And, you know, I think there's also like a lot of weighing of risk that happens, right? Like, so if I'm talking about overdose risk, that's going to be different than talking about HIV prevention risks, right? There's some overlap and some similarities, but not entirely. And so like, you know, there's a lot of misconceptions around, commonly like people think that using meth isn't a risk for overdose, which is completely untrue.
You know, and I'm looking back, Haven, here just around safer use. And if you're, let's say you're in a clinical setting, right? These are some bullet points that you can think through, you know, now or later, where, you know, what you were talking about is like, how do you talk with someone if you're working with them? How do you acknowledge when you don't know? How do you ask for clarification? How does your education happen kind of maybe outside of that moment? Like there are manuals, there are resources. One of my favorite things, one of my favorite ways that I learn is with harm reductionists on Instagram. Like that is like, I think one of the best, most current topical, really amazing, worldwide perspectives on harm reduction. But then also kind of, again, thinking back, if you're in a clinical setting, clinical or community setting, like, how do you facilitate the disposal, the collection, the provision, collection, and disposal of used syringes? If you don't, do you know where the person that you're working with can go? Like, these are some just like really practical questions to think through if you're working with people who use drugs in like any setting.
I also want to just jump in on this because I think this happens a lot where we start focusing on safe disposal of syringes. To be clear, that is harm reduction in the way that it keeps money coming. Like, syringes discarded in the community are not dangerous, right? It is not a public health threat to have syringes on our street. Is it litter and gross? Yes. All litter is gross, but it is not actually a public health threat. There's never been a documented case of somebody getting HIV from an accidental needle stick in a community setting ever documented. So, and hepatitis C, those numbers, there's been a handful of cases that were all in people who are baby boomers, or also known as being in the birth cohort, where there's a lot of undiagnosed hepatitis C anyway. So I think, yes, getting rid of syringes is really important, and talking to your clients about how they dispose of their syringes is really important, mostly because it keeps the neighbors from yelling at me about the syringes in the community. But I do think it's really important to like understand that that is not a public health threat. That is not a health threat. That is something that keeps our programs politically viable. It keeps us from getting yelled at. But disposal is important. Litter is bad. And disposal is low on the list of importance in terms of promoting health and dignity.
And I should, as always, thank you, Haven. And I should just kind of clarify too, like, I think about, especially for folks who move around a lot, and if they're living outside, like, well, then likely they will know where they can dispose of syringes, but it's like one less thing that someone has to deal with. Like, hey, you can drop off your sharps container here. We can take that for you. We can offer them to you. Like, this is about, and I'm really glad you say that, because the infectious disease threat is not high. It's not documented. It is not existent in the state of Oregon. And from a person-centered perspective, if you're working with someone one-on-one, how is that just kind of one more thing that you might be able, if they want, to have a conversation around. So I'm going to move us along and talk, as my dog is jumping over here. So Syringe Services, we've covered this a little bit before. Syringe services are often a really big component for people who are injecting or shooting drugs. Often folks will know where they can go and get help, but like, are you as providers or care teams, are you aware of what that looks like? Do you know what day of the week, what parts of the city, what some of the different services are that are offered? How do you have that conversation with someone? If do you feel comfortable doing that? If you don't feel comfortable, you're probably not the right person to be doing it. But just how can you be informed of the types of services that are available? So we're going to talk about different types of safer use that are not about syringes. So let's spend maybe like 5 minutes on this before we do our closing.
Yeah, so most people who use drugs aren't injecting them. Like, the vast majority of people who use drugs aren't injecting them. I think Justine and I both have like a skewed sample set because we both work in syringe services programs. But it's really important to remember that most of the meth use that happens is smoked. Most of the cocaine use that is happening is not injected. You can inject any drug. If you can get it liquefied, you can inject it. And I'm pretty sure I've had clients who tried injecting all of them. But, I think it's really important. And so, when we're talking about harm reduction services, like thinking through, are you providing safer snorting kits? So, there is some risk, although it's low, of transmission of bloodborne infections through Coke straws, things like that. So making sure people have things they need to properly and safely snort drugs. Putting dollar bills up your nose, real gross, real high risk for infection. Those things are dirty. So using clean supplies. I think one of the things we talked a lot about with, especially early in COVID, is looking at smoking is really dangerous if you're sharing smoking equipment, right? Like we've got this respiratory pandemic happening and people are out there sharing pipes and sharing, you know, smoking utensils, and like that is super high risk. We don't offer pipes at our exchange because of monies. We do offer foil for folks to smoke off of in order to help kind of keep some of those things happening. Actually, it was about a year and almost 2 years ago now, the Oregon Health Authority identified a spike in in HIV, specifically associated with folks who are using methamphetamines, both injection methamphetamines and smoked methamphetamines. And people are often like, well, if it isn't sharing needles, what is it? People on methamphetamines have sex, right? And so really like thinking about like how we can keep people smoking is really a great harm reduction tool. Like if what I don't want to have happen is someone be like, and I've actually had this conversation, the first time I went and bought foil to have in the exchange out of my own pocket, which is how I pay for it, because it's not in my budget, was because I had this like kiddo, like 18-year-old youngster, come in and tell me he needed help learning to inject because he usually smokes his heroin but didn't have any foil. So we fixed that. We got him some foil, right? Because it's harm reduction. It's safer for him to smoke it than it is for him to shoot it. So really like, yeah, go ahead.
Well, yeah, I wanted to bop in when we're talking. There's like, yeah, we could talk literally for hours. Don't worry, we won't keep you that long unless you want us to. But some things around, first, like harm reduction and safer use. So like, for example, like when we give out our snort kits, we call them party packs, they have condoms in them. And like, where it's just like, hey, and we offer condoms, but it's also like the more places we can offer opportunities for someone to have access to a resource that they might need. Because yeah, there are some drugs that like that increase people's sexual appetite. And so let's be real about that. And let's offer the tools that support someone to stay healthier with that's happening. And regarding smoking, which has been another issue that has been more debated. And it's interesting to just notice how some of the thinking around that has changed given this respiratory pandemic. And I will admit that I was more hesitant around distributing smoking pipes, when I understood them to be illegal, which distributing them is not illegal in the state of Oregon. And there are other ways, I see you, Haven, where like if you don't, they're also really expensive. And so how do you almost like harm reduction your budgeting in that way? So is it offering more alcohol wipes and recommending to folks that they clean pipes before sharing them? Chapstick, so people's mouths might not blister and crack, because what happens is if someone has open blood that gets on a pipe that is then shared in someone else's, in an open entry source. So like, how can I love harm reduction in a way. And it sucks that we have to think about making those decisions. And there's the world that I think Haven and I and many people on this call want to live in, and maybe we'll get there, but also like, what do we do given the world and the constraints that are very real that we live in now? So yes, dear.
I was just going to point out that like you're feeling weird about pipes. That comes from the public health brain, not the harm reduction brain. Like we can make it pre-COVID. It is a stretch to say that people are getting HIV from sharing a pipe or hepatitis from sharing a pipe. It's a stretch. Like we don't see it documented. Like it's happened. It's not. That's not how we do it. So it's harder for people to like click that, having that pipe is actually reducing harm. I know, because I've had to make that argument, and I've been making that argument for years, that it's like, it's a good engagement tool, right? To like engage with smokers and get people in. But it also like, it's harder for people to sit with until they start thinking about smoking reduces your overdose risk. You're like, yes, you can still overdose if you're smoking, but it does go down, right? smoking, your HIV and Hep C risks decline dramatically smoking. So those kind of things. But anyway, I can go on again forever. So let's.
No, yeah, well, we'll keep on moving. And I think Haven and I have both, and we can send resources out after, but like the Harm Reduction Action Center has some really just great, clear, simple visuals that are health literate that can give you more information on safer use. So we encourage you to do that. We're basically at time. So I think maybe we could go for just a couple more minutes and maybe quickly talk about language, because I also think, Haven, you brought up earlier, what to me feels more more relevant and important is like relationship and self-care. And so I would like to make sure we address that for like 1 minute. But first, language matters. The words that we use impact how someone else is perceived. And so this is a great visual made by our friend and fellow researcher, Robert Ashford, that really just encourages you, if you're a normie like myself, that says like there are certain words that really aren't available to you if you're not in that community. And also when we're in provider settings, when we're in political settings, like when we're writing about people, like you don't call someone an addict. You don't call someone a junkie. You don't say the homeless, like as in they're people. They're a person who uses drugs. It might be a person who's living outside. And so just going to plant that seed. Other people can talk about it in greater depth and probably more eloquently than we can right now. But I think the takeaway is like, don't call someone an addict. Even don't say substance abuse, talk about substance use. Like when we can use more kind of neutral words and less judgmental words, we decrease the stigma that someone experiences. That's my dog barking in the background.
Welcome to Zoom land.
But I'm wondering, okay, wait, Haven, we had reflection thoughts. Do we have time to talk about like self-care for harm reductionists?
I mean, I'm terrible at self-care, so I'm not the best person to talk about my self-care is a glass of wine, couple cigarettes.
Okay, which is all self-care. That is self-care.
It gets messy, my friend.
Okay. So then maybe let's pick up the thread. Let me try it from another angle and then see if you have anything to offer, and then we'll close out and be available for questions. But I'm really, and I'm glad you said this, like talking about when I'm like, look at this cute poster of like a kitten and a dog, a bear. And you're like, okay, responding to overdoses is scary and it's traumatizing. And I really want to come back to that, to not minimize for the people that you're working with and for you. Like as someone who has responded to overdoses, who does overdose education to people who have responded to millions more overdoses than I likely ever will in my life, one of the first things I say when someone's getting more Narcan is, you know, thank you. Like, thank you for coming back. Thank you for being there for your friend. Just even acknowledging like that moment, like you brought your friend back, or you lost your friend, or we lost our friends. And how is that
really empowering for like doing the naloxone trainings is super empowering for people and super like, it's a moment that is hard and bonding, right? Like you bond with the people around you and like sit with that trauma and like, yes, honoring the like humanity of the event is really important. But you know, like trauma is a key, like, I don't know, I wouldn't say all addiction is rooted in trauma, because I think any kind of all statements are ridiculous, but we see so much trauma in the community. And I think that experiencing an overdose, whether it's fatal or not, can be both traumatic and empowering at the same time.
Yes, I'm glad you offered that. And I think too, and unfortunately, so many of us are not provided the opportunity to do this, but like, how are you metabolizing this trauma? How, you know, what is your relationship to self-care? How are you naming it or practicing it or not practicing it, and being okay if that's not happening at the time, but maybe hopefully working towards it. And I say this as like, not the conversation that we will complete in this meds ed training, but just to bring that to the table more, like where when we're talking about harm reduction, we're also talking about inherently the experience of trauma for everyone involved. And
loss.
Yeah, yes. And to how can we not just like be tender with ourselves, like first and foremost, but also like, again, when we think about systems, how do we offer systems that are more caring? That are more caring in response.
Yeah, I mean, I think it's tricky, right? Like I mean, this week I lost 2 people I know, right? And that was just this week. Last week there were more, and the week before there were more. And so like, it's a community of really grounded in grief. And I do really worry about those of us who've been doing this work for a long time and who are out here in this time that is exponentially harder because of COVID, where many of our traditional coping mechanisms are not available. And so I do like, how do I metabolize it? To be honest, I fight like hell.
Yeah.
Like every time I lose someone, that is more fuel on my fire to help create a better system. It's what keeps me showing up for presentations like this, where especially in like this format where I can't even tell if people are liking this or not. I hope you are. Please be saying nice things in the chat. I can't look at the chat and talk at the same time, but I really like, that's what keeps me going, and that's what keeps me showing up. I've been doing this work since 2002, so almost 20 years. And I think, is it important to like reflect and take space and like all of that like healy stuff? Yeah. And I will be the first to admit I'm terrible at it. Like I'm terrible at self-care. But that like activism spirit, and it comes back to that activist root where harm reduction comes from community taking care of itself. And I am proud to be a part of that community. And so that's what keeps me coming. And like, I keep pushing for change and keep hoping that we can create systems that are loving and kind and respectful.
Thank you for like being honest about that, Haven. And then I also think, again, for everyone who's on this call who may or may not be resonating or liking it, but it's like, how do we continue the conversations around community care and self-care and have them not just be buzzwords and acknowledge the very real loss and trauma? And also like, I mean, I feel ya, like what keeps me going is the fire. And especially often the flames are fanned by loss. And I also though have to like say to myself a lot, like less heat, more light, because I don't want to burn myself out. I don't want to burn all my bridges. I want to keep that passion going, but also I think sometimes just acknowledging like, how are we coping? And tend to ourselves. But I don't know. I mean, again, I think we could talk forever, but we should probably go. But like, we're available. Like, obviously, if people want to talk with us about this, we like to.
we can talk about this for like, they only gave us an hour. That's probably just not enough time.
Oh my gosh. Pauline, are you guys there? They're like, we're gone.
We are here. We are here.
Oh, we're here. All right. That was fantastic. Thank you for that. We are not only informed, we're also completely entertained. I think it's time that we get a podcast going for you too, so we can continue this, because your level of energy is off the charts. So thank you for everything. You see what I mean, friends, about being really passionate about this work? It's clearly something you just don't let go of very easily. So I think we're very, very fortunate to have these two share their constant work that they're doing in this field here today. So thank you both, Haven and Justine.